Hi, my name is Jeff Kirsch, and I'm honored to serve you in the role as president of the AUA. I wanted to welcome you to our 2021 annual meeting and thank you for your participation. These have been very difficult times for us, and I'm very appreciative of you taking the time to participate in this virtual meeting. I would also like to thank the members of the Scientific, Education, and Leadership Advisory Boards for putting together such a great meeting. And finally, I would like to thank the administrative staff of the AUA and IRS, including Kristen and Vivian, for their incredible creativity and support of our meeting. Thank you.
The introduction, pleasure to be here discussing some of the healthcare disparities and the role of having a diverse workforce to help us through. My name is Maya Hastie. I'm an associate professor of anesthesiology at Columbia University, and I have no conflicts of interest. We'll start with a few definitions. One way to understand diversity is using this framework that uses both primary and secondary characteristics. Primary characteristics are those that are inborn, that are difficult to change, and have a major impact on how we view the world and experience it. Those include our race, ethnicity, age, country of origin, gender, sexual orientation, mental and physical abilities. Secondary characteristics are important, but they change throughout a lifetime. These include education level, our work experience, political beliefs, or religion, for example. Another aspect of definitions that we need to make are what are stereotypes? These are the building blocks of how we make meaning of the world, how we place things in categories to understand things faster. Biases are when we make assumptions based on those stereotypes, when we make assumptions about a person's abilities because of an aspect of their identity. And finally, we get into discrimination when we build practices based on those biases. And whenever there is a power structure, we end up with systems of oppression. In medicine, we have engaged for decades in patterns that have led to discrimination. The AMA was engaged in systematic segregation against Black physicians, and the NMA was started in response and is currently the voice of over 30,000 Black physicians and the patients they care for. The Flexner Report in 1910 led to the closure of over 90 medical schools back then based on the lack of resources they had. It also led to the closure of 5 of 7 medical schools that were dedicated to the training of Black physicians. Hill-Burton Act was enacted in a way to help support hospitals and healthcare facilities to provide them with federal support for renovations and improvements. However, in order to be passed, they had to place a provision for separate but equal. It wasn't until the Civil Rights Act that discrimination against race and sex and country of origin was considered unlawful. There's another important aspect of the Civil Rights Act is that it separated intent from impact. We didn't have to prove intentionality of the discrimination for it to be unlawful. And finally, as a result of the Civil Rights Act, in 2020, the US Supreme Court made into law that employment discrimination based on sex or on sexual orientation was contrary to the Civil Rights Act. In 2020, of November 2020, the AMC changed the name of their award, of the Flexner Award, because of the recognizing the impact that Flexner's report had on discrimination against Black physicians, and because of his racist and sexist beliefs that were expressed in his writings. In medicine, we've engaged in a lot of discrimination as well in the way we approached our patients. In the 19th century, there were theories of racism and racial superiority that fed into the American eugenics with the belief that some genes were superior, and that led to selective and involuntary sterilization of Native American, of Black women, and of Puerto Rican women. Sims, the father of modern gynecology, experimented on enslaved women without their consent. The Tuskegee experiment withholding treatment from Black men who had syphilis. And Henrietta lacks her immortal line, which was obtained without patient consent and without family information. And it's not only our history. Even in the recent present, Dr. Suzanne Moore reported the racist treatment that she had when she visited the emergency room in December of last year. More recently, the CDC director warned us that racism is a public health threat to our community. Lack of diversity in our workforce is one element that drives these elements of discrimination. In anesthesiology, less than 5% of residents are Hispanic and less than 5% are Black. And we are dealing with a limited pipeline. There are also gender and racial underrepresentation within our societies. At the AUA, we found that 72% of our members and 26% are women. These are the results of a survey that was sent in 2019 to all of the members of the AUA, and the results are the results of responses of 475 members of our group. At the AUA, we do not represent the society we serve, we do not represent the population we serve, and we do not represent academic medicine or academic anesthesiology. Nationwide, Black men amount to about 13% of the population and 18 or 19% Hispanic men. In academic medicine, those numbers drop sharply. In academic anesthesiology, still a major problem, but at the AUA, Black men are severely underrepresented, so are Hispanic men, Black women, and Hispanic women. The impact of lack of discrimination, of lack of representation and discrimination on individuals can be large. Those minor slights that are experienced every day can feel like a death by 1,000 cuts or a ton of feathers. And they can be internalized and leading people to feel a sense of lower competence. At the organizational level, as Dr. Rena Kronish described, diverse teams are smarter, and exclusion of qualified individuals lead us to blind spots. But most importantly, patient outcomes suffer because of those discrimination actions. Black women are 3 times as likely to die during birth compared to Hispanic or to non-Black patients. Cardiac outcomes are also important. More than twice, the Black men have more than twice the risk of dying from heart-related causes. They're less likely than white men or to be admitted to cardiology units from the ED when they present to the emergency room. In anesthesiology, how we manage pain is different based on patient's race. Even antiemetic prophylaxis is different when we are administering it, and there are healthcare disparities related to that. Inclusion of the race factor in calculation of GFR leads to an overestimation of kidney function of Black patients, and that leads to delay in referrals, delay in kidney transplants, and even in the operating room, leads to errors in drug dosing. On the pediatric side, infant mortality, Black infants are 3 times as likely to die before their first birthday compared to white infants. And some of it is related to maternal health issues, but some of it is also related to who is taking care of them. When Black infants are taken care of by Black physicians, their mortality rate drops sharply. Even the technology that we use has discrimination built within it because a lot of those equipments are tested on white men. And in a recent paper from the Michigan group, they found that pulse oximetry tends to overestimate the real oxygen content in the blood of Black patients compared to white. The road ahead is long. And as Dr. Martin Luther King has said, of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. Dr. Lanefall is going to talk to us about next steps and how we approach some of those systems. This QR code is scannable and will lead you